Welcome to this presentation this afternoon. We're going to be talking about chronic wound management, addressing the challenges of diabetic foot ulcers. We have a very esteemed faculty, some gentlemen that I've known for many years. We have Dr. John Lantis. He's a professor of surgery at the Icahn School of Medicine at Mount Sinai, formerly Columbia University. He's the vice chairman, Department of Surgery at Mount Sinai and also St. Luke's and Roosevelt Hospital in New York City. We also have Dr. Thomas Serena, who is the CEO and the medical director of the Serena Group out of Massachusetts. And lastly, myself, I'm Dr. Rob Snyder. I'm director of clinical research at Barry University, where I also serve as a full professor. The learning objectives are pretty straightforward. First and foremost, we're going to look at the relevant statistics and the depth and breadth of diabetic foot ulcers and the disease in general. We're going to discuss the science and some of the evidence surrounding many of the products that we use as advanced therapies to prepare the wound to heal, particularly in the diabetic patient. We're going to be looking at the role of silver, negative pressure wound therapy, ORC collagen, installation therapy, as well as epidermal grafting. I think you'll find many of those topics very interesting, and hopefully some will be new to you. And of course, we're going to also explore some interesting cases that will utilize many of these therapeutic regimes. So I'm going to start out with an overview of foot ulcers in patients with diabetes. When you look at diabetic foot ulcers in general, obviously it's a very, very serious complication, but it is one of the most common, if not the most common reason why diabetic patients actually wind up in the hospital. They usually have infections that will require that type of intensive care. The annual incidence is 4%, so you're looking at about 26 million diabetics in the United States alone. 4% is a pretty large number, but the lifetime risk is even greater. It's 25%. 15% of all diabetic foot ulcers result in lower extremity amputations, and 85% of all lower extremity amputations are preceded by an ulcer. Now, in general, the catalyst for the ulceration is neuropathy. But of course, at the heart of this, and the reason why most people will ultimately succumb to limb amputation, is because of peripheral arterial disease and infection. For those of you who haven't seen this statistic, it's very, very daunting. 1 million amputations globally in patients with diabetes. That's one every 30 seconds. So just think about how many minutes you're going to be spending in this room, and it kind of gives you a sense of how many amputations are performed globally. And Harold Brem did a study in the United States, and he found, this was a number of years ago, that there were about 1,200 major amputations performed every week in the United States. And it's very likely that since that article has been written, that number has increased. This is a very serious problem. In fact, research clearly shows that diabetic foot ulcers are as serious as some cancers. And if you look at this slide, you can very, very easily see that if you look at prostate disease, if you look at breast cancer, if you look at Hodgkin's disease, the 5-year mortality rate is actually greater in patients with neuropathic diabetic ulcerations. Of course, it's also far more costly to treat a neuropathic ulcer than it is to treat some cancers. So if you think of this logically and pragmatically, the obvious, at least the most obvious reason why diabetic patients die is because this is a disease which is a devastating, very serious, whittling away disease. It's a decaying process. So when you think in terms of why diabetic patients die when they have diabetic foot ulcers, the logical conclusion would be they have diabetes. This is a very serious disease, and they're succumbing to that disease. But this study may change your mind. This was a study done in Norway on 63,000 patients. And what they did was they looked at diabetic patients that had a history of foot ulcer and those that did not have a history of foot ulcer. The underlying comorbidities were relatively similar, and they followed these patients for 10 years. And what they found was at the end of 10 years, the 10-year mortality rate increased by 47% in those patients that had a history of a diabetic foot ulcer. So what does that tell you? Just having a neuropathic foot ulcer is a marker for death. Every single time we hold a diabetic foot ulcer in our hand, just keep in mind that this is a seminal event in this patient's life. And not only impacting the patient, but impacting the patient's family as well. Patients unfortunately become defined by this disease, and it ultimately takes their life prematurely. Now, we also know from many articles, this is just one of them by Finn Gottlieb and colleagues, looking at the need for a multidisciplinary approach to treating these very difficult and complex patients. And what Dr. Gottlieb found was that utilizing a multidisciplinary approach with a vascular team in place, as well as a wound care division to this team, that amputations can be lowered by 75%. So it clearly shows, and the message here is that we are not sitting here on an island by ourselves. We cannot be treating these patients alone. We have to work with our colleagues, we have to lean on our colleagues, and we have to do what's best for the patient in this multidisciplinary framework. Now, clearly, infection is also a very, very important aspect of why individuals lose limbs. This study by Lipsky clearly points out that at least 60% of patients in this study that lost their leg lost it because of infection. That seems like a pretty straightforward problem. Well, patients have infections. Why aren't we just treating their infections, and why aren't they just getting better? So looking at this pragmatically, we look at risk factors in general. We look at wounds that penetrate the bone, wounds that have been open for long periods of time, wounds that are dirty from trauma, and also wounds that have a duration of at least 30 days. Seems to be simple. The problem is that diabetic patients have immunopathy. They don't mount the same physiologic response as a person who didn't have diabetes. So you don't very often have the cardinal signs of infection: heat, pain, redness, and swelling. Very often they're absent, and in fact, Gardner's study, done several years ago, pointed out that 20% of patients with infections that have diabetes have no symptomology at all. So we have to be looking at what Gardner called secondary signs and symptoms of infection. Certainly, the catalyst has to be viewed in terms of peripheral arterial disease. We cannot heal patients without good blood flow. But we also have to be looking at pain and an otherwise painless foot, and deterioration of the wound, even absent signs and symptoms of infection. And according to Gardner's study, there's 100% specificity and 100% sensitivity with pain and wound deterioration. So we have to be looking at those secondary signs and symptoms as well. And of course, this was very, very important and categorized very nicely and summarized very nicely in the 2012 Infectious Disease Guidelines of America on the diabetic foot relating to foot infections. So how serious is this problem of infection? Well, when you start with an individual that has a relatively, quote, innocuous wound, probable contamination, if this person calls you on a Friday at 4:30 and says, I have this ulcer on the bottom of my foot, you need to see them. Again, this is a seminal event in this person's life. Why? Because the spectrum is very clear. We move from a relatively what we call innocuous, but clearly no wound in a diabetic patient is innocuous. Very, very quickly, this can escalate to a local cellulitis with adjacent infection, and again, very quickly to progressive necrotizing fasciitis. And everybody in this room understands that once it escalates to this point, there's a 20% mortality just relating to the necrotizing fasciitis. So you have this spectrum that occurs in this patient group, and the same is true of patients with peripheral arterial disease. They may start out with just a hypoxic situation, or they may have some type of ischemia, but it isn't necessarily that serious. This can very, very quickly escalate to something which can be devastating and certainly very clearly lead to an amputation over a very short period of time. So how are we doing with standard care? Well, this is a study done by David Margolis. It's from 1999. The study is not new, but I think it is as compelling today as it was in 1999. This was a meta-analysis, basically where Dr. Margolis looked at two endpoints. He looked at 12 weeks and he looked at 20 weeks to see whether or not standard care, offloading, debridement, and moist wound healing would make a difference and allow these patients to heal. And what he found at the end of 12 weeks is less than 25% of patients healed, and at the end of 20 weeks, less than 31% of patients had healed. So that was a wake-up call for people in the wound care space to say standard care in this patient group often doesn't work. And we have to begin thinking very, very seriously of using advanced modalities and advanced therapies very, very early in the treatment paradigm. Peter Sheehan did an article in 2003 looking at 4 weeks as a surrogate endpoint to see whether or not he could predict wound healing by week 12. And we were very impressed with that study, so we repeated it on another subset of patients. And what we found is if patients didn't improve by 50% area reduction within the first 4 weeks, the likelihood of healing by week 12 was very, very low. And in fact, in our study, it was 2 and 5%. So if you reverse that number, basically 95 to 98% of patients that don't reach this threshold will not heal by week 12. So this is not a positive predictor of healing. This is a negative predictor of healing. And we also found that it didn't matter how large the wound was. If it didn't get 50% smaller by week 4, then it was unlikely to heal. And we also found that we could even predict at week 2 if the wound was deteriorating or the wound had plateaued, that the likelihood of reaching that 50% threshold by week 4 was very remote. So we can even make that choice earlier. So what is this? This is a call to action. It is unacceptable to think in terms of using advanced therapies very, very late in the game when you have nothing else left. These therapies have to be used early in the treatment paradigm. And there's a lot of evidence this type of work with these benchmarks and these endpoints and these surrogate endpoints have been validated at least 3 or 4 times. So we know that this is the truth. And if they reach 30%, they're not going to heal by week 12. They must reach at least a 50% threshold. So kind of looking at an overview and looking at this holistically, we have peripheral arterial disease. We have trineuropathy, which is sensory, motor, and autonomic. We also have altered wound healing, particularly the fact that fibroblasts don't function appropriately. Remember, every time you take a step, you have repetitive trauma over and over and over again. Now, that coupled with diabetes leads to the scenario of the diabetic foot ulcer. So there are many ways of classifying diabetic foot ulcers. One way is to look at them as either neuropathic, neuroischemic, or ischemic. Now, if you think of a true ischemic ulcer in a foot, it's usually very distal. It's usually in the toes. It looks like someone took a hole puncher and punched holes in the toes. It's usually black because it's necrotic, and it looks like bats are going to fly out of it. It's a very serious problem and certainly a tell. And very often patients will develop pain in their feet despite the fact that they have profound sensory deficits. But we look at the neuropathic ulcer very, very often as kind of the standard of what we normally see. But there is a blurring of the lines from a vascular standpoint in all of these. It's just the degree of vascular problems. So if you think in terms of the fact that you have a patient who has a palpable pulse and a normal ABI and actually even a warm foot, but the wound is not healing, and you're terming that neuropathic, not thinking in terms of the fact that you actually have a steal mechanism going on where you have an atriovenous shunting of blood away from the skin. And because of that issue, you actually have not a neuropathic ulcer, but a neuroischemic ulcer. And Alexandru and colleagues looked at this very carefully and found that wounds in general that were termed neuropathic, 60% of the time were actually neuroischemic. So we cannot overlook the fact that patients who have inadequate blood flow will not heal. So looking at the pathophysiology again and looking at those things that are most important for us to be looking at, we have to be evaluating for infection, for ischemia and hypoxia. And remember, you have ischemia, you always have hypoxia, but you can have hypoxia in the absence of ischemia. Offloading inappropriately, smoking, anemia, COPD, etc., etc. You have to be looking in terms of that. cellular failure, particularly in terms of fibroblast function. Pressure, trauma, extremely important in this patient group. Inflammation, age. Age is always a factor in wound healing. Doesn't matter what group you're dealing with, what ulcer type you're dealing with. Age is always a factor. So these are all consistent with a common final pathway to individuals that will not heal. And one way to remember this, and again, you can memorize this list, but one way to remember it are the VIPs: vascular, infection, inflammation, and pressure. So if you just remember those three letters, very often you will cover a multitude of these areas that we're talking about. Now, Bill Ennis made a comment. You all know Dr. Ennis, vascular surgeon out of Chicago. He coined this phrase, and I like to use it because it really kind of encapsulates how we should be looking at this patient group. What he said was, think like an internist before you act like a surgeon. We all tend to walk in a room and we look at a patient for 5 minutes and you pick up a blade and you start cutting things. It just doesn't work that way. You have to understand the medicine. You have to understand everything you can about the patient, everything you can about the wound, so that you can make appropriate decisions as to how to proceed, because there's a very subtle balance between medical and surgical therapy. We also have to be looking at these patients holistically from patient factors, physical factors, the macroscopic environment and the microscopic environment as well. You can almost look at these as core healing principles, a holistic view of how patients should be treated. So let's kind of dive a little bit more deeply to see what happens from a biochemical standpoint. Well, first and foremost, you have unresponsive or senescent cells. Are senescent cells dead? No, they're sleeping. The problem is if you do nothing to stimulate those senescent cells, you will get replicative senescence. So you'll have the same process over and over again, and you will have non-healing. Non-migratory hyperproliferative wound edges. Many of us don't realize the fact that you must cut out this hyperproliferative wound edge and at least bevel the edges so those keratinocytes that are sitting in the epidermis can move. If you don't do this, then those keratinocytes will marginate around that hyperproliferative wound edge, and you will not have healing. Of course, in acute wounds, you have low levels of proteases, but in chronic wounds, you have high levels of proteolytic activity, particularly MMP 2, 8, and 9, and serine elastase. Now, why serine elastase? Because you're in a chronic state of inflammation. And in the inflammatory phase of wound healing, you have tons and tons of neutrophils. So serine elastase comes from the neutrophils. You have deficient and or unavailable growth factors, of course, so you lose that chemotaxis and proliferation. You have faulty receptor sites, so even if you do have adequate growth factors, they will not hook onto those cells, so they will not fire and create biochemical pathways which are needed for healing. And lastly, of course, you have high levels of bacteria, which also create their own enzymes. So those enzymes will destroy whatever is in its path. So if you look at an acute wound, think in terms of sitting on a beach somewhere in Puerto Rico, looking at the sun and the sand, and life is good. It's a nice nurturing environment. A chronic wound is a toxic waste dump. That's the difference. And of course, it's our goal to change that paradigm. So you have this circle, if you will, and you have to break into that circle and rebalance the wound microenvironment in order to get wound healing to occur. And this will require, not only on the part of everyone in this room, but I think as a profession, this will require a paradigm shift in how we view things. We just can't throw dressings and therapies at the problem. We have to understand the wound microenvironment. We have to understand the science behind wound healing, and those areas and that knowledge will help us choose those products and therapies which will work best for our patients. Now, all of you know that there are many clinical practice guidelines out there. Some of them are pages long. They're very complicated. They're very convoluted. What do we tend to do with them? We don't read them because of just for this reason. They're complicated. The print is small. There's millions of different pathways. But then when you look at something like wound bed preparation, although this is a very simplistic tool, It's very, very powerful. Why? Because not only are you looking at the wound, you're looking holistically at the patient. You're looking to find out patient-centered concerns. You want to know everything you can about the patient. You want to make certain that you have the appropriate etiology before you begin treating, before you pick that instrument up and start going to town and doing what you think you have to do. And only then think in terms of dealing with the wound. And one easy way to remember this algorithm is DIME, D-I-M-E, debridement, control of infection, inflammation, moisture balance or imbalance, and wound edge preparation. So you have two different sets of things you need to be looking at, the VIPs and DIME. And if you do you get nothing else out of this part of the lecture but those two elements, then I think you've learned a lot. Now, this wound bed preparation model is very important, not only because it helps heal wounds, but it also will lower the risk of infection as well. So let's look at some essential questions. What can we do to prepare the wound to support healing? Number two, what can we put on the wound to rebalance the wound microenvironment? And number three, what can we do to sustain healing after it occurs? So I feel very, very confident that my esteemed colleagues to my left will be able to answer many of those questions. So without further ado, I introduce Dr. John Lantis.
Thank you very much. And I'm definitely going to steal the wound that has bats flying out of it. My residents are going to love that one. Okay, so we're going to talk really about wound bed prep at this point in time and focus a little bit on what we can do to reduce bioburden and also improve granulation tissue probably after debridement. Obviously, we're quite familiar with what we do to cleanse a wound. We debride it. I will say there's some interesting things that we've had come out of our research, which we're not going to go into in detail today. But one of those debates that you'll hear at times is whether you should prep a wound before you debride it or not, even in the office setting. And we actually have shown that we have better reduction in planktonic growing bacteria if we do prep the wound bed before we debride it, interestingly. I know it's still controversial, but we actually prep the wound bed with something that's antimicrobial and then debride it at this point because of our own research. We usually maintain the wound in a delayed fashion because we don't want it to close inappropriately, and this would be removing the callus from the top so you don't end up with a situation where you have an abscess. We have our variety of wound dressings, which we probably have at least 2,400 of, and if you go downstairs, we probably have 10,000 of. And some form of drain, and repeated returns to the OR or repeated debridements and cleansings, or a whole portion of it. So there are a variety of ways that we use negative pressure wound therapy to reduce the host environment that is negative. We're pretty familiar with some of these mechanisms. We know that we can reduce local edema. There is definitely literature that shows, using some interesting technologies that are beyond the scope of everyday practice, that you increase localized blood flow. We definitely know that negative pressure wound therapy promotes granulation tissue. Reducing bacterial colonization is quite questionable and is maybe not always that important. Developing a synergy between the bacterial burden and the host is probably much more important. We definitely know that negative pressure wound therapy allows for moist wound healing, and we have enhancement of epithelial migration through both microstrain and macrostrain, and uniformly we can get the edges to come together. Well, what about decreased bacterial burden? Well, there are a variety of trials out there that show that the reduction in wound size is not linearly related to the bioburden. And actually in 2010, one of my fellows was lucky enough to win the Young Investigator Award at this meeting. And what they had shown was that in a porcine or pig model with infected wounds, that despite increasing bacterial burden under negative pressure wound therapy, you actually got increasing or improvement in the wounds and increased epithelialization. So it's hard to prove that the bioburden alone is a mechanism of improvement with traditional negative pressure wound therapy. almost any data you have seen to date in regards to the Bioburden Challenges, and you hear many talks here and at other wound care symposiums in regards to planktonic bacteria, and of course we all talk about biofilms. Well, planktonic bacteria are what you culture routinely, right? Planktonic bacteria are what you, if you do a quantitative culture, you send to the lab, they're growing bacteria. They are not living in a glycocalyx. You basically need a research lab, and we partner with Dr. Greg Schultz in regards to our biofilm work because there is no standardized way of looking at biofilm. Biofilms are the non-replicating bacteria that we know exist in wounds. We are finding out that it appears that in about 75% of wounds that have significant numbers of planktonic bacteria defined as greater than 10 to the 5th, there is a biofilm. So in 25% of wounds with a lot of planktonic bacteria, it's very hard to identify a biofilm. So not all wounds have a biofilm. We do know that sharp debridement, mechanical debridement, is the best way of removing biofilm. But biofilms come back within approximately 10 hours. That's why this morning you brushed your teeth. You got rid of your biofilm. And the night before you go to bed, you'll brush your teeth again because biofilm's back. Because tartar's biofilm, right? So we have to remove it again and again and again. And that's one of the reasons that we change dressings on wounds, in part, not to just deal with the exudate, not just to deal with pain, smell, etc., but we're actually often doing something about the biofilm. And for all the WOCNs in the world who have had to throw rocks at all these surgical residents that you've had to tell not to do wet to dry dressings with, the problem with wet to dry dressings are wet to dry dressings actually do remove biofilm. The problem is they also remove too much other good stuff. But that's why you'll have all the old curmudgeon surgeons, sometimes like myself, who say, oh, wet to dries work great because they make the wound look really nice forever. For the next 5 years, the wound's going to look okay. So how do we go about doing taking care of these wounds? Well, in surgery, in general surgery, in podiatric surgery, in orthopedic surgery, there are a variety of ways out there. And there's the irrigation idea. This is the high-pressure irrigation of a wound where you blast the tissue in the operating room, usually sometimes at the bedside. It's nice when you do it at the bedside because then you can spray bacteria all over the room. It's good. They can get on the patient, the other patient. It can contaminate everybody. But all types of irrigation techniques, and they tend to work relatively well, although there's questions whether you actually push bacteria into the tissue. There's the lavage technique, which is the run the water over it technique, that doesn't really do much. And it turns out that how the men in the room do the Sunday morning dishes technique works the best. That's the insulation technique, and you all know what you're talking about for the guys. You cook some eggs for the family, then you put the pots in the sink, and you hope that the stuff goes away by itself. Well, that's the insulation technique. But actually putting fluid on a wound and letting it sit there and then aspirating it back off turns out to be the best way to loosen up material and get it to leave. But interestingly, episodic debridement, which we think when you take the patient to the OR and you debride them, or you send the patient to the OR and you have them debrided, or they come to the clinic and you take out a curette and you debride the wound, you think, well, we've reduced the bacterial burden and the wound's much cleaner. Well, the wound is much cleaner. It could be 90% cleaner. That's 1 log reduction, right? You want 3 log reduction for adequate reduction in bacteria to clean a wound. So you may have taken the wound from 10 to the 7th bacteria to 10 to the 6th bacteria, right? You've gone from 10 million to 1 million bacteria per gram of tissue. Is that good enough? No, it's not. It turns out that, and this is a project that we had, that when you debride wounds, whether you use a high-end debriding device such as a hydrodebridement type therapy you might use in the operating room, or use sharp surgical steel, and then we've replicated this outside of the operating room, you actually only reduce the bioburden on quantitative culture by about 1 log. Interestingly, you decrease the biofilm more by debridement than you do planktonic bacteria. And it kind of makes sense because you have one group that's actually sitting in this film that you can remove. You have the other group that's growing. And they can be growing, remember, as deep as 5 millimeters deep in a wound. So they'll come up from the bottom as soon as you've debrided the top. So you don't actually get wounds that clean by surgical debridement. We showed that total bacteria reduction, well, it might appear statistically significant after debridement, as you see here, is, again, not adequate because, unfortunately, you can do a study that shows that you have a 90% reduction in bacteria. And this is one of those things where it's clinically irrelevant, but statistically significant. And you got to be careful of trials and studies like that. So the take home from this is that debriding a wound alone does not leave you with a clean wound that you can then go extrapolate that it's all ready for your next therapy. So there's the role of topical antimicrobials. And one of the problems with topical antimicrobials are that most wounds tend to have multiple species of bacteria in them. One of the things is when you get your bacterial culture, you tend to get the one bacteria that's growing the most. You get the MSSA because it's at 10 to the 7th. They miss the gram-negative rods that are 10 to the 3rd because the plate's covered with MSSA. Now, a good lab that you really work with can help you elucidate that better. But it's very hard to have a topical antimicrobial that takes care of all the issues you have. What we have out there are a whole host of dressings that you see on the left, your left, that are mixed with what they can deliver. And you have a variety of topical dressings, and the way I look at them is moving from absorptive capacity and matching that with therapeutic effect. And you have things such as starch molecules that are mixed with a low level of iodine that actually can do a very nice job of killing bacteria, all the way down to something like negative pressure wound therapy that can be used with a topical antiseptic. That for us is probably the most effective way that we've been able to show in killing both planktonic bacteria and biofilms, and therefore getting a wound bed ready, especially larger wounds. So for us, negative pressure wound therapy with installation allows us to deliver a topical solution that most of the time, and this is a whole other conversation, but we have really looked at this as a way of delivering a topical antimicrobial that we can uniformly kill bacteria with. We're able to remove that fluid, and we don't mix that fluid with the rest of the patients in the room and other folks. We have the beneficial effects of negative pressure wound therapy, specifically microdeformation and macrodeformation going on in the interim between our cleaning cycles. And it's sort of all-in-one therapy for us. So there's a whole variety of testing in regards to this, some of it benchtop, some of it in vitro and in vivo, and I'm going to move through that relatively quickly. And this is KCI data, but it's really Greg Schultz's data. But it shows that you can have a very good effect on biofilm with a variety of agents. And if you get over here on the side, to the right of the screen, you'll see that the hypochlorite solutions have more of an effect on biofilm than normal saline does. Now, it is true that under negative pressure wound therapy with installation, saline itself appears to have a salutary effect upon the wound bed and can help the wound bed as well. So it may not all be the effect of an antimicrobial versus something to do with washing away matrix metalloproteases and some of the negative effects that are in a wound or diluting that environment, such as Dr. Snyder alluded to. In addition, looking at a slightly different model here is just looking at again, using a pigskin model. These are not living animals. That they had an installation 6 times over 24 hours with a 10-minute soak time under negative pressure wound therapy with installation. The agents tested were sodium chloride and PHMB. And as you can see here, the reduction in the actual biofilm, was significant with the PHMB. Now, one of the things that's interesting is the basic science behind PHMB says it probably should be on a wound for about 20 minutes before it has a really good effect, but that's maybe without the effect of negative pressure wound therapy. You have to remember that a lot of us use negative pressure wound therapy also as a way of delivering therapy to the wound in a positive interface fashion. In the most notable example of this is using NPWT on top of skin grafts or other biologics. And it might be a way that you deliver the therapy better. We don't know that to be the case, but that you're actually pushing your therapeutic deeper into the tissue. There's no data to support that. That's just my hypothesis. One of the clinical questions, though, that's raised by this is what agents do we use with negative pressure wound therapy with installation? How long do we dwell those agents? And how long should we provide negative pressure? And there is not a right answer for this. And probably the right answer would turn out that different bacteria need different choices. right? Almost all the biofilm data you saw that was in an animal model is Pseudomonas biofilm because it's the easiest thing to duplicate. Of course, not all your wounds have Pseudomonas in them. Right? They certainly don't have Pseudomonas biofilms in them. Also, the different agents take a different amount of time. Dakins is a very reactive agent. It's actually what we use, quarter-strength Dakins, and has a very short dwell time. PHMB, again, the basic science says it needs 20 minutes. The data hasn't supported that completely in this setting with negative pressure wound therapy. So we have this grouping of agents that are out there that have all been used, and we're going to move through that in a fairly relative fashion. This is our data again that was published back in 2012, and what you're looking at here is the use of Dakins for planktonic bacteria in lower extremity wounds. And you can see that when we use the Dakins solution over the period of 7 days, we reduce the biofilm or the planktonic bacteria very significantly after debriding the wound. So what we did was debride a wound, humans, real humans, not animals, not, so real in vivo work. So we debride an infected wound, and then we put on negative pressure wound therapy with installation. At the end of 7 days, this was the difference for our group treated with installation therapy with quarter-strength Dakins. The group that you debrided and you put standard negative pressure on, those patients actually did well and their wounds looked pretty good. But if you looked at their bioburden had gone back up at the end of a week after debridement. So we hadn't cleansed their wounds as much as we might like. With the hypochlorite solutions, which is what we use, probably the parameters include a 5 to 10 minute dwell time, and you can use the negative pressure at your standard settings at 100 to 125 ranges. Now, they can be treated for very long periods of time, and this is from Tom Wolvis's work. But you can use a solution for a long period of time and have nice outcomes. Standardly, since it's an inpatient therapy, we tend to use it for just a 7-day period prior to going on to the next phase. We feel that we can get our wound beds prepped, massive wounds, 600 square centimeter venous stasis ulcers, or something of that nature. We can debride those and get those prepped and ready for closure within 7 days of debridement. That keeps going the wrong direction. The Georgetown data, I think you're familiar with, is the biggest study so far looking at Proteases. And interestingly enough, they looked at 6-minute dwell times versus 20-minute dwell times. And they compared negative pressure wound therapy with and without installation. Now, a very busy slide, but you'll see on the left you have 6-minute dwell time, and on the right, 20-minute dwell time. And the take-home is that probably the 6-minute dwell time with PHMB worked out a little bit better, which is somewhat interesting because, again, it's counterintuitive to the basic science. And one of the things that we're going to have to pay attention to is when we choose our dwell times based upon the agents, we also may have to change how we think about the agent that we're using because of the addition of the negative pressure wound therapy. It may be a different delivery technology for how we're putting the wound in, because all that data before has basically been in Petri dishes, not in humans. This is human data. So when using negative pressure wound therapy for 6-minute dwell time, you can see that when they had the percentage of patients who were improved, 90% were improved, or 19 of 21. Very sensitive. 19 of 21 when treated with installation therapy. 59% all bacteria improved versus 40%. And the percent closed, much more statistically significant. 94% closed over the period of time versus 57%. So negative pressure wound therapy with installation is a way in a lot of our hands to close the wound faster, and we also don't have to take the patient back. Interestingly, in a patient or in a non-human study, an animal study, you'll see on the your right-hand side the thickness of epithelium that, of granulation tissue that is demonstrated when you use saline with negative pressure wound therapy in an animal model. And for us, those of us using negative pressure wound therapy in partially ischemic patients, we have seen, and Luc Thiot has published the most on this, but I've seen it personally as well, that we get more granulation tissue in our marginally ischemic patients under negative pressure wound therapy with just using saline. And we don't have to kill the bacteria. So there's obviously some other effect as well as changing the bacterial burden in those wounds. Isotonic solutions have been published about and very short installation times. None of these have been particularly standardized. This is the actually the Luc Thiot data, a large series of patients over numerous centers in Europe. Europe tends not to like topical agents so much, so they tend to use saline. In France, they won't use anything else in negative pressure installation than saline. And they have short durations, and it really is a whole grouping of folks. But again, they found very salutary effects with improved healing rates, mainly in patients who had actually failed negative pressure. And one thing that has not been answered, but for patients who you've tried negative pressure on for certainly sacral pressure wounds, which can be very difficult, this might be an area that you want to explore as well. That's just an editorial comment. So, as you can see, this grouping, this particular publication showed that, and this is a finish up of that data, this group had a very nice wound closure rate of 98% when installation was applied, and about 50% of the patients had actually failed previous negative pressure wound therapy. So for us, you can have a patient who has end-stage renal disease and actually had a failed popliteal to dorsalis pedis bypass, who after debridement and negative pressure wound therapy, with installation, her wound went from the picture on the left to the picture on the right. So for us, our protocol is to obtain a quantitative culture prior to debridement, debride, pulse irrigate. We actually obtain a quantitative culture post-debridement and place negative pressure wound therapy with installation directly in the operating room. We set our device at a 10-minute soak time, so we allow Dakin's quarter strength onto the wound for 10 minutes, and now we've moved from a 50-minute soak time. All the data I showed you from our site had a 50-minute suction time, has moved to a 3.5-hour suction time. So we've gone to a less frequent numbers of soaks per day, if you will, which allows better canister utilization and other things, and we've seen no change in our clinical outcomes. There's a variety of other experience out there using the other agents, and none of those are seminal. We need to think about what we use, though, and I think there should be a change over time. Unfortunately, right now we have to adopt the technology, then we have to adopt agents, and it's going to take some time to figure out what agents to use. So for deep wounds like this, in a Charcot foot with negative pressure wound therapy, this is also a patient with end-stage renal disease. She got much more shallow from the left to the right, with a significant decrease in her gram-negative cocci and rare gram-negative rods at the end, from having 10 to the 6th, the bacteria. Thank you very much for your attention. I will turn the regenerative process over to my good friend Tom Serena.
Thanks, man. All right. Well, thank you very much. And I get the chance to show some actual case studies, which gives me a slight advantage. So I'm actually going to start with something that both of my colleagues have mentioned already, MMPs, the bad guys in our wound healing process. They're called matrix metalloproteases, because there's a metal inside, there's a zinc inside. And there's a couple different types, as Dr. Snyder was mentioning. There's the serine proteases, which are we typically call human neutrophil elastase, and there are also these matrix metalloproteases. Under normal conditions, these do a lot of really good things. If I were to take you and simply suck out all your MNPs, you would kind of fall into a big heap of nothing. So they normally function in a lot of processes, like dividing off epithelial cells so they can divide across. How do epithelial cells actually get from the edge of the wound to start migrating? Well, they have to be cut, and MMPs do that kind of thing. So we need MMPs. The problem is that in our chronic wounds, as we've known for some time, there's this marked elevation in MMPs. So what you see here is human neutrophil elastase and MMPs, and on your left, you see that they're markedly elevated in all these different types of wounds, and this is about 30 times too much of this human proteases. Now, just as an aside, because last year I was here at the fall meeting and somebody was on the podium or panel or something and was talking about proteases and got a little mixed up. See, all these proteases are produced by the patient. None of these we're going to talk about now are bacterial proteases. These are ones that are caused by the fact that we've got neutrophils in the wound and that we've got the cells in the wound producing all of this inflammation. And that's basically what MMPs and human neutrophil elastase are, they're inflammation. So if you want to play a little MMP Jeopardy, it's 2, 8, and 9 that are elevated in chronic wounds, and this is a fascinating part. MMPs are really fascinating for a lot of reasons, and one is that MMP9, if you look at that, there are clinical trials now going on in abdominal aortic aneurysms, and they're giving patients doxycycline to decrease MMP9 because it may be what's causing the development of aneurysmal disease. And some studies we did in joint, if you get early degenerative arthritis, so if your knee's starting to hurt right now, it might be due to the fact that you got too much MMP9 being produced in your knee joint. So it's not just wound care that these are exciting. The 2, 8, and 9 are exciting, but all across any disease process that involves inflammation, and that's pretty much all the diseases that we deal with. So in some work that we did looking at MMP9, looking at MMPs and human neutrophil elastase, we said, well, let's take a look and see how much is a bad thing. So what you see here are a couple different thresholds. There's that 90% probability of non-healing. And you see how the slopes of these lines kind of go up like this? Well, when they're going up, that's bad. And it just turns out that it's better to be lucky and good sometime we're doing research. And it just turns up as right was that those slopes start to go up. If you look at wound healing, most of those wounds are not healing. Now, this particular study we did, I think, had a couple hundred patients in it, but we've done this now on literally thousands of patients. And in 2000, I think it was 2014, we looked at elevated protease activity in more than 1,000 patients. So these numbers actually hold pretty true. So there's a number of studies that have also shown elevated levels of these MMPs in chronic wounds, these collagenases, gelatinases, those numbers we talked about. And then human neutrophil elastase, which is the one in diabetic ulcers. So we know there's a lot of these bad things in wounds. This is not surprising if you've been sitting in that seat at SCWC for any length of time. You've heard all of us talk about these elevations. All right. So as Dr. Snyder showed earlier from the works by Rob Kersner, there's a lot of reasons that the ulcers don't heal. There's unresponsive cells, the wounds that don't, the cells that don't migrate, and then what I'm talking about now is this hostile environment where there's just simply too much of these MMPs and human neutrophil elastase. All right. So one of the products that's available is oxidized regenerated cellulose in combination with collagen, and in this product you have about 45% ORC and you have about 55% collagen. And what does that do? You put that in the wound, and the ORC sticks to the zinc. Now, I told you before, it's called a matrix metalloprotease because it's got a metal in it. So if I have something that sticks to the metal in the middle of MMP, it's going to change the shape of the MMP, and it won't work. And collagen works as a sacrificial dressing for MMPs. So the MMPs see the collagen, instead of eating your patient, they eat up the collagen instead. So this can ORC collagen can very effectively reduce those elevations in MMPs and human neutrophil elastase in chronic wounds. So the benefits of the ORC collagen in combination is that it binds more MMPs, and the ORC helps also with human neutrophil elastase. Again, ORC, as I mentioned, acts by binding and inactivating the MMPs, primarily binds to that zinc moiety in the middle. It stimulates cellular proliferation, and it protects growth factors. So one of the things we know that those MMPs do is they divide the growth factors and inactivate them. So your growth factors aren't going to work. You know, one of the reasons that we've added growth factors to wounds, and I don't know how many clinical trials we have done over the years, and I've thrown growth factors into wounds, and I can remember all the acronyms of things I've put into wounds. And I think we just didn't have it right back then. We didn't understand what was in the wound. We didn't realize how hostile an environment was. You take a growth factor, you put it into a wound, and it just ends up being food for the MMPs. So one of the things that ORC collagen is going to do very effectively is protect the growth factors that are being produced in that wound. It can be used with and without silver. If you're worried about bacterial burden, you can add a silver salt to the ORC collagen silver, and that'll also help with bacteria as well. So looking at clinical evidence for collagen ORC, there have been 3 randomized controlled trials in diabetic foot ulcers, 3 in venous leg ulcers, and 1 in pressure ulcers. And you can see as we go down there, the couple of venous leg ulcer ones had improved healing rates. One of these studies, Rob and I were involved in several years ago. There's another one in diabetic foot ulcer showing improved complete healing. Another one that shows complete wound closure in DFUs, and then one in complete closure in pressure ulcers. So it's pretty robust. And look at the numbers, 7 RCTs in 569 patients. That's a lot of patients when you pull all this data together. And when you look at this one this is the one I mentioned earlier that Rob and I are recently looking at, and what we really saw that was fascinating in this trial was that when we put the ORC collagen silver on these patients, they had a rapid improvement in healing. You know, when we've been talking about 4-week healing points, and Rob was mentioning, you know, these. If we see how things are healing at 4 weeks, then we can predict how they're going to heal down the road. Well, what we saw in this trial was that at 4 weeks, the patients treated with ORC collagen silver were markedly there was a marked increase in the healing rate in those patients, and that's how we use it. Now, in this study, we did follow it out to 12 weeks, but I have to be honest with you, I don't think I'd use ORC collagen silver for 12 weeks. It's not the way we practice, but at that time that we did the trial, we designed it that we had designed it, everything was designed as 12 weeks study. Today, I would do this as a surrogate endpoint study. I would just study it for 4 weeks. I wouldn't study it for 12 weeks. But we learn as time goes on. So if you look at that 4-week data, very impressive, marked reduction in that. And at this point, I have to tell you something. I probably would have, at that 4-week point, that's when I would have used Celitome or something else to take it to closure. I've modulated the proteases. I've made the wound now more receptive to advanced wound care. And I have to tell you, my practice today, the step after 4 weeks wouldn't have been to continue ORC collagen silver. It would have been to use suction blister epidermal grafting. And that's a nice segue. We'll talk about blister grafting. You know, I did plastic surgery training as well as general and vascular, just because I never really knew what I wanted to be. So if you're in plastic training, you look at this reconstructive ladder, and the idea is to heal the wound at the bottom of the ladder, because that's where there's less morbidity associated with the procedure, less complications. And skin grafts have been a mainstay of that. There's lots of different types of skin grafts. There's autografts, like take skin from one portion of your body and put it on another. Allografts, that take skin from one human and put it on another, usually some kind of prepared skin products. Xenografts, you can take animals from grafts from all sorts of animal sources. You know, I was giving this lecture about 3 months ago, and I said every farm animal is now represented. And someone in the back of the room, a gal in the back of the room, said, ducks. I said, what? She said, ducks. There's no product that comes from ducks. So I have to change this now to say that every farm animal is represented except ducks. And there's biologic skin grafts, which are human living cells, and composite grafts. You know, in plastic surgery training, for years we did pinch grafts or epidermal grafts. So it's not anything new to the practice of surgery. And then there are a lot of different ways to harvest epidermis that our dermatologists have been doing for quite some time, taking pinch grafts or cultured autografts. But suction blister grafting has really become the standard, particularly in our dermatology, with our dermatology colleagues. There's quite a bit of efficacy and I was surprised by this, to be real honest. But suction blister grafting has been well studied in Europe and in Japan, and has been used in several clinical trials. This is a patient with a diabetic foot ulcer trial in which they looked at 20 patients who actually had exposed bone, and they rongered off the cortex and then put epidermal grafts on, and actually found that there was a significant reduction in the amputations in that group. So if suction blister grafting has been so great and introduced in 1964, why haven't we been using it more? Probably because it was a pretty hard thing to do. So if you can do suction blister grafting in the past, you take this 60cc syringe, you take out the plunger, you hook on a stopcock and then a piece of hose, and on the end of that hose is your surgical, medical student or resident like this for an hour trying to raise this blister, and been there, done that, and and then it takes about an hour and a half to do that. It's not very practical, certainly not going to be anything we're going to easily accept. So how did it develop? Well, before it was a product that is being promoted by Acelity, we had a great place for us to start using it. And this story really begins in Haiti after the earthquake. This is the first week of February in the Medichère Hospital in the Port-au-Prince airport, the Tent Hospital there. And you can see the dressing change dressing change tent is there on your right. And the infection rate in Haiti at this point was 70%. I mean, everything got infected. So we actually used negative pressure wound therapy in order to protect the wounds, not only to treat them, but to protect them from getting infection in this situation. But jump forward 2 years now. So 2 years, it's August of 2012. Rox Anderson, who was the original inventor of the Cellutome device, and I share an office in Cambridge, and he's showing me the device that he's used for vitiligo and hypopigmented disorders, and I said, no, I have a place for this. We need to take this back down to Haiti because we can do great basic wound care there, and they do a fabulous job at basic wound care, but what they don't have is advanced products, and getting a skin graft, a split thickness graft in Port-au-Prince is not an easy thing to do, and it's actually a major deal. So we actually took the device to Haiti for the first time. This is Dr. Francis Adler, actually his hands, and he's a general surgeon. He runs the wound care center at in Port-au-Prince, and he's putting on the harvesting device. You can see it's a little grate. And you turn the machine on, and it heats the skin to about 40 degrees centigrade and applies about 400 to 500 milliliters of negative pressure. And then what happens over a period of time, which is somewhere between 20 and 40 minutes, you'll have the epidermal blister grafts or microdomes will rise, and then you can harvest them. And here we're putting in a piece of foam. I use foam for highly exudative wounds that I'm going to place on the recipient site, and then I use Tegaderm for low exudating wounds. And then what you see is you get 128 1 millimeter blister grafts, or microdomes that adhere to either adhesive foam or adhesive Tegaderm. Adaptic, we've used Adaptic as well. All of them work very nicely. For the longest time, I was worried about this because you can see those are folded. There's epidermal, and they look like tacos. And you really don't. I really worried about that for a long time because what I really wanted them to do, and we harvested skin, for months on different types of foams and things to try to make them look like chalupas. So it turns out that, and I mentioned this in case you see this, it doesn't really matter. Tacos work just as well as chalupas. The epidermis is really smart, and it can reorient itself. The donor site's treated with simple Tegaderm, and then just like any skin graft, we will need to secure it into place. So let me share a couple of case studies. This is a patient with a diabetic heel ulcer. It was treated with a dermal replacement. That's not necessarily a necrotic material. That's kind of left. It's not the greatest picture. It's kind of leftover dermal replacement. We put on the skin, the microdomes. We covered it with negative pressure, wound therapy. And then this is the first dressing change. Really nice granular response. And actually, there's a little bit of undermining that really was improved in a short period of time. This is you can see the grafts on the Tegaderm, and if you're going to use it under negative pressure, you either have to use the Adaptic, or you can need to put holes in it using the. This is me making another mistake. How do you know you're an expert in a device? You've made every mistake with the device possible, and don't use scissors on Tegaderm. It makes a mess. You have to take a needle, like a 14 or 18 gauge needle, and poke holes in it. Now more and more people are using the Adaptic, and I think that might be a much better choice for dressings in this situation. Although I tell you, the Tegaderm, if you're patient enough to put enough holes in it, works pretty well. This is 15 and 18 days post-grafting, and 3 weeks. And I'm sorry that there is a slide that shows it's almost healed, and that gentleman, I can tell you, did go on to subsequent closure. He was grafted twice, and that was used a second time in combination with hyperbaric oxygen therapy. This is a patient that I met in 1997 when we opened our first wound clinic outside of Pittsburgh, Pennsylvania, and I was still practicing full-time wound care at the time. And now jump forward to 2013. This is I've seen him every year since that time. You can see he's lost all the toes on that foot. He's lost all the toes on the other foot. And he's probably had 6 or 7 ulcers over that time frame, or maybe more. And this was the 2013 version of that. So we've debrided it. We've done moist wound healing. All the things that Dr. Snyder mentioned were important for wound bed preparation to get this wound ready. And it was day 1 for hyperbaric. That's why the HBO's on the little tag there, because he was going to start hyperbaric on this day. You know, I read a lot of work that T.K. Hunt had done on epidermis, and in epidermis, the response of epidermis to oxygen. Epidermis really likes oxygen. And so we said, well, this is a perfect gentleman to put on epidermal grafting as he begins the process of hyperbaric oxygen therapy. This is a week later, 2 weeks, 3 weeks, and he was completely closed in 4 weeks. Now, the beauty of this is I had 7 previous ulcers treated on this gentleman, and I can tell you that the fastest we'd healed that before was about 10 to 12 weeks, and that was the fastest. So this was considerably faster. Now, do I have an RCT to share with you to say that that hyperbaric in combination with epidermal grafting in the treatment of diabetic foot ulcers? No. I mean, we probably have a dozen or so cases. It's something I find very interesting. And I know that all of us as a group have talked about beginning to look at this a little more scientifically and perhaps do some kind of at least prospective case series to take a look and see if perhaps this combination really makes a lot of sense. And you get to see it twice. All right. I think that's it.